Hello, good morning. Thanks to everybody for coming out on a Saturday morning. My name is Sean Stone. I'm a Senior Program Officer for Community Human Services. And this is Amy Bravo, Executive Director at Valley Health Associates. Before we get into the training, we just wanted to say special thanks to Montage, Prescribe Valley Health for being able to provide the injectable Naloxone, as well as CHS were fortunate enough to be able to provide the nasal Narcan. So what's really important is that you guys are all taking the time out of your day to be able to support your family, your friends, loved ones, but really the community, so you're getting tools for your tool belt. So, anything else?
I just think that, this is a small group, which is an intimate setting, which is really good because if one of us can save a life, then this is all worth it, right? I just went to a DHCS training in LA this past week, and we did a lot about correctional settings and medication-assisted treatment and overdose. And they said that it's all an estimated 92-93% of overdoses happen when you're released from incarceration, coming out of a residential treatment program, or coming back from a relapse. So these are all high risk, and relapse and overdose happens all the time. And I'm really excited everybody can be here. I see YMCA's here and Century Center's Peninsula Prevention Team. So you have a lot of providers and a lot of programs and partners that make this possible. So thank you all for being here. And Rev or Casey?
Yeah.
Sure. Or basically just to introduce, I'm Rev Case. I'm an emergency physician at CHOMP, one of the lead clinical physicians for the Prescribe Safe initiative, and absolutely honored to get to do this work and to try to help and make a difference in our community.
Thank you.
I'm Casey. I'm an ER doc. I grew up in the Monterey Peninsula, and I am now the medical director for the CHOMP ER, which is an interesting job since I get to handle all the complaints, which has certainly taught me a lot about customer service. I saw that on a little outline we had in the other room, we were going to talk about the science of addiction. So I think I'll briefly start with that, if that's okay, and then we'll kind of segue into how this happens. So what's really incredible is I went to medical school, obviously, and I went to where I thought was a good medical school, which was UCLA, and they didn't teach us anything about addiction. Reb, did you get any addiction treatment? No. I did my residency at Stanford, pretty good place, nothing about addiction. And so then magically I was supposed to know how to take care of problems with addiction when I started becoming a doctor at CHOMP. And so the simplest way to think about addiction is it's all about dopamine. All right? So in your brain, you have a chemical called dopamine, and that dopamine makes you feel good. And it goes to way back in time when survival was in question. So blueberries, I love blueberries, they taste good. I get a little dopamine rush that lets me know that makes me feel good, it makes me want to do it again. Love, sex, shelter, community, all of those things promoted survival and caused a release of dopamine. And the problem with a lot of these drugs is that they hijack the dopamine system. For example, so I've had a really good day today. My wife and I did Taekwondo this morning. My daughter gave me a hug at the end of Taekwondo. My dopamine levels are high, they're about 80. Okay? When I go to the ER this afternoon, and if, let's say, someone dies of an overdose and it's a child and we're all devastated, my dopamine's going to be at a 40. Okay? When you use methamphetamine for the first time, your dopamine can go almost to 1,000. Or if you're predisposed when you drink alcohol or use opioids or use Xanax or maybe marijuana, your dopamine levels can go up to well over 500. And so what ends up happening is your dopamine system breaks, meaning that you start using so much dopamine because of the drug that you run out of dopamine in all other circumstances. So I'll pick on Reb. So let's say Reb was using marijuana daily and she was getting these big dopamine rushes from the marijuana. Without the marijuana, there's no dopamine. So she's depressed, miserable, and that substance gives her the dopamine back. And so if you've ever wondered when you've met or taken care of or had a friend who's addicted, why would you do that? The answer is they're craving dopamine because that's the hormone that makes us feel normal and good and connected and loved. So, and I'm sure I will see someone this afternoon when I work in the ER who is addicted, and the only way they can feel normal is with the drug. And so the hope is with all of our treatment programs here, Valley Health Associates, Community Human Services, and Sun Street, is that when we get people into treatment, we allow their brain to heal so dopamine goes back to normal. And what's really hard is it can even take several years. So why do relapses happen? The dopamine system is still broken and it takes time to heal. And unfortunately, people tend to remember that dopamine feeling, and so that's why relapses can even happen further down the road. So today, what we are going to talk about is when someone's dopamine system is broken and they overdose, we can save their life and get them into treatment to give them a chance to get better. I was talking about it with one person. There's another funny thing about addiction is that actually that dopamine system being broken becomes so powerful that it overrides our frontal lobe. The frontal lobe is the part of the brain that gives you the, I'm going to go kick this person, ooh, wait, on second thought, I'm going to get in trouble, I'm not going to do that. And the dopamine system is so broken that it overrides the frontal lobe. So we were talking about mayonnaise and drugs. So if I told the room, hey guys, Target has bad mayonnaise. Who wants to go buy bad mayonnaise? No hands, right? With people with addiction, they crave the most dopamine they can. So if they heard that this person just overdosed, I want those drugs. Which is one of the reasons why opiates are so problematic, is because people want the best high, and that best high is so close to the edge of overdose. And if anyone has heard about fentanyl recently, it's in Monterey County. I'm sure Officer Rice can tell us about the experiences that he's had with fentanyl. I know we see it in the ER. Fentanyl is 100 times more potent than morphine, and so it's so much riskier. But people who have that broken dopamine system know that the fentanyl is going to get them so much dopamine, and so they're willing to take the risk. And so here we are today, learning about how to save that life to get people into treatment. Does that all make sense? Questions? Yes?
Antidepressants, do those do anything with that dopamine situation?
So it's funny you should mention that. So my dog woke me up at 4 in the morning last night to go to the bathroom. And as I was trying to go back to sleep, I was looking at a class of drugs called dopamine reuptake inhibitors. So the idea is that Prozac addresses depression by saying that serotonin, which is kind of a hormone that makes you feel kind of happy and content, is low, and it blocks the brain's reabsorption of serotonin so the levels go up. And so I was actually just wondering, are there dopamine antidepressants that could address this? And the answer is, no one knows yet. Because the dopamine is what drives the addiction, the antidepressants that don't really focus on dopamine aren't as effective. But if you got started on drugs because you were depressed, and the meth made you feel less depressed, and so you kept using it, an antidepressant could help the underlying depression that made the drug use worse. Yes?
What about lithium?
Lithium. So if you're bipolar, and one of the things I know about bipolar, Greg, you can feel free to comment, is a lot of it involves with more impulsivity. So somebody is more likely to make a rash decision, and that can again contribute to relapse or getting started in the first place. So if you are bipolar, treating the bipolar will help treat the addiction and help you to heal altogether. But lithium specifically doesn't do anything for addiction.
And if they're using lithium, heroin again?
That's, I'm trying to think, do they specifically interact? I don't know if they cause a specific problem. If you're toxic on the lithium, like you have too much lithium in your system, that can cause sedation, which will combine with the heroin to cause more sedation. But it's no different than like being on amoxicillin, which is an antibiotic, is that every drug has a unique side effect, and when you combine drugs, the risk of them interacting goes up. All right, so I'm going to embarrass Reb as the physician whose brainchild this collaborative effort was called Prescribe Safe. And if you want to talk about the case that made you start this process.
Yeah. So I came to the peninsula in 2003, brand new, attending out of residency at UCLA, and I'm shocked to see what I felt was my cohort, young women, that were in the emergency department for problems associated with addiction. Didn't recognize it, didn't know to look for it, had no idea what I was doing. As Casey said, there was no training. It was just, this doesn't make any sense to me. Why are we having this interaction? Why is this happening? And so we started dealing with it on an individual basis. Mary, this is not going to work. Mary, how can I get you care? How can I help you? What can we do? And we developed a program at Chomp to take individual patients and try to figure out what is causing their turmoil, truly, which is what so much of this is, and how can we address that. So we did that for about a decade. And then the case that flipped me on my lid was a little kid that came in. He was 19 months old, and ultimately he died of an opiate overdose. And I am a different person today. And so I'll never forget, he wheels in, and it's CPR and a little schmack, and it's a little kid. And I don't understand. I don't have anywhere to put that in my brain. And so ultimately he dies, and we follow up everything that happens. The officer that was investigating and I were very close in contact about this, and ultimately it was an opiate overdose. And prior to his death, I had started realizing it wasn't just Mary's problem, and it wasn't just John's problem, and we couldn't deal with this onesie-twosie. It was a problem, like bigger than each individual person. It was a community problem, and his death changed that, changed how I was going to handle it. So I'd been in contact with, talking to some physicians down in San Diego, because they were starting to deal with it as a community effort. I'd made friends up in Marina County with their public health officer. They were starting to look at it as a community effort. I was like, I'm in. You need somebody to spear this down here. I am the girl. So that's how this started. And how it continues is last shift, I had a young man came in from an overdose, and we got him back. His brain seemed to have gotten through it without significant damage that I can tell so far. And as he and I were connecting and talking, he was like, what do you mean you'll offer whatever I'm ready for? I'm like, If it's clean needles, done. If it's just getting you naloxone and getting it for your family, done. If you want to start considering recovery options, done. Whatever you're ready for right now, we will make happen for you. And so that's how this whole process is evolving, is years ago when it was Mary and Dave and individuals, I don't know what I'm seeing, I don't know how I can help. Because of all the work and everything we brought together after that tragic case and how we realized it's a whole community effort, now anything that anybody's ready for, harm reduction is what we will do. Anything you need us to do, we're ready for. And it's this community that has made that possible.
I have to say I was embarrassed when I got to Jump in 2013. I didn't realize we had any drug treatment programs in the county. I was like, why don't we have any drug treatment programs? And was really physicians not being educated enough, because there are so many great programs in the community doing great work, and we just didn't know. So now, when Officer Rice saves someone on the street, thank you Seaside Police, they come to Chomp, and we actually now have connections to get people into the great work that's being done by our treatment programs. And I think I like this term, I'm going to coin it. It's the chain of survival. It's the rescue, it's the stabilization, it's the ongoing treatment. So in fact, actually, if you want to come up and talk about your experiences, if anyone doesn't know Officer Rice, he's awesome. We love him.
First, I want to thank everyone for coming, because it really shows that people care about our community and our peninsula, and they want to be educated to make a difference. So please give yourselves a hand real quick. So real quick, I've been a police officer for 3.5 years on night shift. So I actually did a lot of calls involving overdoses and deaths related to drugs. Currently, I'm assigned to SRO. I'm a school resource officer educating children about drugs, which is why I love having a relationship with Dr. Close and Dr. Grover. But the shift in just 3.5 years has really changed for me. 3.5 years ago, I responded to a lot of drug overdoses where I felt helpless as a police officer. The reason why is because we have limited resources. We have an AED, we have a little first aid pack, but fire department and AMR will not come into a residence or a house until it's deemed code 4. That could mean somebody's been stabbed 20 times and the suspect's still outstanding, and then I have to be a first responder and try to save that person while not trying to die myself and find that person. So it's just very stressful from a police officer standpoint, and we feel helpless knowing that you want to preserve life and then serve justice. So as it relates to drug-related calls, I've gone to several scenes where I've watched young people dying or have already died of opioids. So when I met Dr. Grover, through actually prescription fraud, probably like 8 months later, he said, hey, I'm interested in providing Narcan for your department. And I'm like, what's Narcan? He said, oh, it's like a nasal spray that saves lives for opioids. And I'm like, what? No, that doesn't exist. He's like, no, it really does. let me come do a briefing training at your department. I guess, how many departments now do you guys have?
King City just applied, the DA's office just applied, Greenfield has it, Salinas has it, Marina has it, CSUMB has it, Seaside has it, Monterey has it, PG has it, Sheriff's Office has it, which means it's in the jail too, and then Carmel by the Sea has it. Del Rey Oaks has it, Airport has it.
That's extremely successful. Just in the time that we've had it, and me, aside from my current assignment since January as an SRO, the entire shift has changed, where I know now, with the uncertainty of getting a call saying possible drug overdose, possible death, person's unresponsive, I think the youngest we've had is a 17-year-old who overdosed on heroin, probably laced with fentanyl. Luckily, with this new skill, so we always complain as police officers, we have too many tools. We don't like our tools. We have too many. It starts getting heavier and heavier, and legislation just wants to give us more crap to make it go harder. But the really cool thing is nobody complained about this. Everyone was like, this is so unique. We've never heard about it. We have an AED in our car that we never use. Let's give it a try. So sure enough, we put, I think, 2 or 3 Narcan nasal sprays in every car. And for calls like that, usually 2 officers will respond for an unresponsive person, just because of the unknown circumstances. So you could have up to 6 Narcan spray, which is really important because depending on the level of intensity for the opioids, potency, or fentanyl, so you have another doctor and all the fancy words. This 17-year-old, he required 4 sprays of Narcan.
Wow.
I wasn't there for that one, but there's the plus side and the downside. One is you have somebody they live off of wanting this and they need it, and that's all they think about day in and day out. And when they don't have it, they're miserable, they hate life, they hate everyone around them, even though people are trying to help them because their vision and their view is skewed. So when they finally get that euphoria that they are looked for, and then they die or they're dying, and then somebody that they don't know comes in and saves their life, they're going to be pretty pissed off when they wake up because you took away what they've been wanting or what they may not have had money for. So this particular incident, we had a 17-year-old that attacked paramedics and police officers, and unfortunately he had to get arrested. I don't know if he went to the hospital first and then they had to take him to jail, but because he assaulted first responders and police officers in the course of resuscitating him, that was a downside. That's the only downside that we've had so far in our city. Myself, I believe I've had 3 to 4 Narcan saves. I still get that rush of adrenaline because you don't know if it's going to work. Plus, you don't know why. If they're in an overdose, it could be like a seizure that went bad. It could have had internal hemorrhaging. I don't really know, and I get there, and it's very scary to see somebody all curled up or foaming at the mouth, and everyone around them is panicking and they feel helpless. And all you have is this little nasal spray, and you don't really know if it's going to work. And I'm telling you, the magic of it, of spraying it into their nose and waiting like 5 to 7 seconds, and sometimes they just open their eyes and they look around and say, what happened? And it's like, I think we just saved you. You were dying. And really, I've only seen it once where I've actually seen the drugs present. So usually it's kind of just like a best guess scenario where we'll say, hey, hit him with Narcan, we think it's a heroin overdose. We'll ask the parents, does he have, or any family, because they're not always kids, do they have a history of drugs, heroin use? Could they be experimenting? And then we'll hit him with the Narcan. But I had one incident where we saw a spoon and a needle, and I knew right off the back, I told my partner, I said, go get, and this is when we first got it, so we didn't even think about bringing it out on the, like we ran upstairs trying to be like police officers and we're kicking in the door to save people, and we're looking around and I'm like starting to do CPR, and then I'm like, needle, heroin, go get the Narcan. He went and got the Narcan and it worked. So from a law enforcement perspective, having a tool that saves lives, especially for people that need it. I don't think people that are drug addicts are criminals. I know a lot of people think, oh, homeless people, they're just drug addicts that are a leech on society. It really is a problem. It's a disease. I'm not going to get into why they started that disease. They all have their own reasons. But it's the importance of changing our shift in culture from either punishing them to rehabilitating them and changing their life. And the more tools that we have to save them, to show them that, hey, you would have died, but because we have this technology to save you, and then instead of taking them to jail, taking them to Dr. Grover and Chomp and then having them go to all these resources can really impact and change their life.
So as somebody comes out and they don't have the capacity or cognitive reason to understand that what you would term as an assault or a threat to a peace officer's safety, that they would get criminal charges held against them, is there going to be any change in legislator and that to not consider it as they come out,
Mm.
that they have the capacity to not have been fighting, because they wouldn't be seeing officer, they'd be
I think-
reacting to being woken out and not to know where they are or who they are, and then
I
to,
think the answer is it depends, because in that scenario, they knew who they were, and they said, get out of my house, I don't want your help. And before anyone could respond, they said, relax, we just saved your life, we just saved your life. And before we could do anything, they just started assaulting people.
but
So they showed
it
enough cognitive ability, sorry?
It was after.
Yes, it was after this, right?
when
And they
it's,
said, I don't want your help, get out of my house, you're trespassing, and it wasn't even their house, because there's other family that invited us into the house. So I think it's all a case-by-case scenario. You bring up a valid point, because some people may not know what's going on, but for that certain case, which I can't really get into too much detail about, they did have the cognitive ability to know what was going on.
but like with Velasco's case where they put a spit mask on him and they said that he was throwing his mom into, and if he would have lost consciousness, and then there,
I don't know the
then,
Velasco.
it was in 2015.
Oh.
When they're restrained,
Uh-huh.
after that, they come out, and they're moving around,
Mhm.
and you have a short little area in, as that emergency response is taking them to the hospital,
Okay.
and they get charged for assault on peace officers when they have spit mask on, and they're restrained. Are you gonna work along with Salinas PD and the rest of Monterey County to educate and inform that level of threat that is?
So I can comment on this. So when a person has a substance in their system, they're often not able to make good judgments. And that kind of comes back to this, why we're here is we're talking about substance use. And so if somebody's intoxicated, it becomes an interesting question of what they're responsible for. I have the luxury in the hospital of if somebody's getting agitated, I tell my nurses, okay, we're going to give a sedative, we're going to calm them down. And our first responders just have a very different circumstance, meaning that they don't have the same resources, they have to consider scene safety, they have to consider their own safety. And as I'll talk about, we want one victim, not 2, 3, 4, 5. So it really becomes a question of how do you protect everyone involved? And I can't speak to what defines when charges are pressed, but if a person is clearly impaired, we have to treat them as a medical victim. If a person is clearly not impaired, then it becomes much more complicated. I can say from a medical perspective, our goal is to give people treatment, but if Officer Rice gets stabbed, he can't go save the next person. So we have to consider everyone's health in this, and there's not an easy answer.
And I do know, just from a law enforcement perspective, the shift is changing. I'm a new generation of police officers. They were changed differently. I know some people don't like police officers because they're old school mentality, but the culture of law enforcement has changed. And I know I'm a human being and I've made mistakes in my life. We're supposed to be factual and all of the information for our report when we press charges. So in my report, I will articulate that they are under the influence of drugs, and they may or may not have known what they were doing. I gave them several commands to stop. I identified as a police officer, but they may not have registered that I was. And I can say with confidence that most of the times people do get charged with drug-related or under the influence crimes. They'll usually trade it down to the lesser of charging them with just being under the influence.
And the other
So if it, instead of a felony of like a assault on a police officer, it'll just be the misdemeanor you were under the influence, and then they'll make you go through an anger management class and drug rehab.
And the other question I have, because with behavioral health, we've advocated for community as first responders. Officers are trained in crisis intervention training, but is there a way between you leading in collaborative police reform, community policing to hospital, that you can create community as first response underneath you, so we know how to support and follow up afterwards? Because like you said, you're a different type of police officer, you've seen how it works, but as far as family, secondary trauma, and everything like that, does Seaside have anything that they do with like faith-based
For the-
organizations?
So we have to be impartial because we represent the government. So even though I'm a man of faith, I believe in somebody, I can't talk about my political views and I cannot talk about my religious views because it's not politically correct in my position.
But for what I asked is there a community first responders training, besides crisis intervention training? Is
Yes.
there a community
Yes.
first responders training, not asking because the Narcan?
Sure.
Yes, we have a ton of training. We have monthly trainings with all of our CBOs, community-based organizations, and we have trainings with our police officers on constant de-escalation training,
But
which
for
I'm actually,
individuals besides the CBOs?
So I know Monterey better because we're chomps in Monterey, but Monterey has a social worker in their department. That works
Crisis
with Chomp.
5, that's what we call
We
it.
also have a mobile social worker for the county behavioral health that rides with Monterey PD. And then one of the Monterey police officers is an instructor of mental health first aid.
But what about the communities themselves, the families themselves?
So the idea is that in a crisis, we have the victim,
Mhm.
and then the idea is that, and usually that's more of a hospital issue, is that when the family arrives with a victim, we provide social work, behavioral health, if there's a death, bereavement support. I think it's more on us as the hospital to address the family, because our first responders are really focusing on the victim at hand.
Plus depending on the call, I can get CPS involved, I can get so many different organizations. It's hard for me to answer your question because it depends on the call, but I have a book of resources that I can provide for a family, including family counseling, family rehabilitation.
But I was speaking on harm reduction as community as a whole, not from the incident, but even doing.
Like more events like this.
And actually, that way you prepare and you prevent and you reduce harm and how the
Sure.
community response is, not in what's happening with the incident, the officer, and thing, but to prevent harm from officer to responder
Sure.
to everything else. Is there workshops so that people work in when incident command is put into place so that community outside can identify harm reduction strategies before it ever happens and look at what happened and debrief. So
Absolutely. I was going to say, probably we should, when we finish here, we'll go back and look at all the resources from the tables outside, because all of our groups work on projects like this.
And with officers?
Yeah. Do you have a question?
Well, I was just wanting to say that Kinship Center, where I work as a therapist, is partnering with Monterey County Behavioral Health, and they're going to create a adolescent mobile crisis unit. So I just wanted to say that.
Very cool.
All right.
And just to touch on that, as an SRO, we have a youth diversion program. So now instead of kids being charged with crimes, we actually make them go through, they take a Macy's test, they speak to a psychologist in behavioral health, and then they might go through anger management, therapy, Sun Street Center. It all depends. We have so many programs that we'll do, and it all depends if they're experimenting with drugs, if they're being defiant and incorrigible at home, if they're being truant from school. So we have a myriad of things that we can do depending on the child's needs.
All right, we're going to segue into some Narcan training. Go ahead.
Just kind of to finish off the subject here, I understand what you're saying. And then with the youth opioid epidemic as well, we're collaborating with the, at least in Salinas, with the Sheriff's Department and youth probation, because we have a youth outpatient program in Salinas with Valley Health Associates, and it's the first of its kind, because dealing with youth is very touchy and very sensitive, and we're working really hard to create that collaboration to work with law enforcement on that. Okay? And there's information on the table, we'll give it to you, come to the table, give resources, information, just how you could be a supportive community member with this new program that we have. Okay?
All right, then we're going to move forward to the nuts and bolts of how to actually get this. So we're going to talk about three things. You're a patient. How to recognize an overdose, and then how to give the Narcan, and one topic is the nasal, one topic is the injectable. So, I like to keep things simple.
You're keeping things simple, wasn't it?
So, I like to keep things simple. I work in the ER, we have to know a little bit of everything, so simple is good. So you want to think about three things when you want to think about an overdose. A person's poorly responsive, so that can mean that they're confused, they're sleepy, they're unarousable, they're drowsy, they don't look like they're acting right. Okay? The second is that their breathing is going to be depressed. It could be like 1 breath a minute, it could be really shallow breaths, it could be gurgling breathing. And the third is that if it's an opioid, their pupils get really small. We call them pinpoint pupils at the hospital. So look for those three things. And then as Officer Rice mentioned, other things is if there's signs of drug use. Is there a pill bottle? Is there a patch? Is there a syringe? Is there a needle?
Tinfoil.
Tinfoil, yeah. So those are just basically, if at any point you find someone who's not responding well or breathing well, and you think there's any possibility that they could have an opioid in their system, they're ready for Narcan. I'm going to pick on Seaside PD. The other thing to remember is that sometimes people mix drugs. So Seaside PD got called out to a lady who was unresponsive, and they, I guess, knew her from previous interactions with alcohol. And they're like, oh, we know her. She usually just drinks. Except it was her first day trying opioids. And if you actually reverse the opioid, you can get them breathing again, even though there's still alcohol in their system. So even if they told you they drank alcohol, and you still think there could be an opioid in their system, go ahead and get it. Do you want to come do some of the...
Oh, I was just gonna say, so when we do law enforcement trainings, the Narcan, so if somebody has used an opiate and they're high, right, but they're breathing, they're not blue, they're just intoxicated, that's not the point of Narcan, right? If I come across someone who is just, kind of nodding, but not in danger of losing their airway, their ability to breathe, they're not turning blue, I don't think they're dead. That's not a time to use Narcan. It's time to maybe call for help, ask, keep an eye on them, but that's not why we do the training with law enforcement. That's not the purpose of Narcan. The purpose of Narcan is if you come across someone and you assume, I think they're dead, that's when is the 100% appropriate time to use it. Okay, and like you were saying, the blueness of the lips, are they breathing? It's that question. It's not, oh yeah, he's totally high. High is a different issue, and that's what Officer Rice was talking about, the money and the dopamine and where they are. That's when people get really angry for reversals and things like that, which angry people that are alive are fine with me. I don't have an issue with that. But the bigger issue is when to use it and when not. Because people say, well, what do I do? If you think that person's dead, you cannot harm them with Narcan. Cannot. True. If I'm having a massive stroke, bleeding stroke, and you give me Narcan, still have a bleeding stroke. You didn't do anything, one side or the other. So just keep that in mind and don't, what if I hurt them? You can't. There's no possibility of causing harm with this. And specifically if it's used in that situation where I think he's dead. He's either still dead from another reason or not dead because you just saved a life. So, Narcan will bind to the opioid receptor stronger than our opiates, thank goodness. And so it displaces the opiates that are suppressing the breathing, okay, and so basically causing the person to die. It basically moves them out of the way, but it does come off, eventually off that receptor, and any opiates that are still hanging around, fentanyl or whatever, will then bind. So that's why you give the Narcan, you call 911. If they haven't come around, you give more Narcan, and you wait for 911 to arrive. Okay? You cannot harm them. Yes, please.
So we actually had a call where these parents said that or not these parents, they were like family, and they found a loved one and they thought they were dead for like over 30 minutes to an hour. And they were blue, they looked like they weren't breathing at all because they didn't see enough to know the signs of the shallow breathing, the pinpoint pupils. And one of our officers was diligent enough to get down and actually check and be like, this person's still alive, they need Narcan. If that officer wouldn't have been diligent and didn't have the Narcan available, that person would have died. Because when we come across a dead body found, we usually will just call the coroner. So that's why it's important to actually get down and check. And always, you have nothing to lose if they're dead or not. You might as well just hit them with the Narcan and see what happens.
So let's imagine, Amy is volunteering to your patients. Literally, this is how we do it. Are you okay? Are you okay? Can you hear me? Are you okay? Can you hear me? Can you wake up? Can you wake up? Just see, do they respond? Okay? You're doing so great. Thank you so much. Yeah, there's an Emmy on the way. Very nice. Okay, so literally the first step is just, are they responsive? And she might startle and start breathing, and that's good. Okay? Now, if she's not responsive, I'm going to do two things. I need to make sure that I'm safe so that there are not now two victims. So let's say, for example, we're in the middle of the street, or there's, I don't even know, there's hazardous materials, or there's a down power line, or whatever. But just make sure that you're not putting yourself in harm's way. The second thing is she needs definitive medical care. This Narcan is a temporary measure. So, are you okay? Are you okay? Please call 911. First two. Assess, call 911. Now, we're going to do the nasal first. You can sit up, otherwise you're going to forget. But really good position. Okay, so the nasal, I'm going to pass this around. This is a little nasal spray, and the nasal's a little simpler. It's going to come in a blister pack that looks like this. And basically, you open the blister pack, and out comes this little device. And you're going to hold it like you would Afrin, and you're going to slide it up into her nose until your fingers touch her nose, and then you push the plunger. That's it. So, assess the patient, call the paramedics, put it in their nose, push the plunger. Kind of a PED. Okay? And we'll pass it around, and you can practice. That one's spring-loaded, so you can press as many times as you want. What's up? No, it's spring-loaded. Do as many times as you want. And I think CHS brought some trainers too. So, and then,
Ms. Norman has a question.
go ahead.
You're probably going to cover it, but just because anyway, so you spray the first one, it doesn't work, or how long do you wait before you spray again or use another?
Perfect, that's exactly what I was going to say next.
I
Thank you
figured,
so much.
sorry.
No, you're perfect. So, if you want to resume the overdose position again. Okay. So, we go ahead and, okay, we've assessed her, the paramedics are on their way. I put one in the nostril and there's no response. You can relax your neck again for a sec. If you look at this one, the little plunger has gone in. So, once the plunger has gone in, it means it's used up. And so you can't give it a second dose. The plunger is physically in. I'll pass this around too. Okay, the box of the nasal has 2 sprays, and so if they don't respond, you can assume the overdose position again. Okay, that's good. I'm actually going to go in here, and I'm going to go into her nose, and I'm going to give a second dose in the other nostril. Very nicely done. Now, someone was asking, what if they're upright? Won't the medicine leak out? And the answer is no. It's in a fine vapor that sticks to the inside of the nose, and it gets absorbed through the soft, fleshy part of the nose. So let's review. Assess your person. Are you okay? Are you okay? Are you okay? Call 911. Take out your device. Push it in the nose. If they don't respond in 2 minutes, push it in the nose again. There you go. Now, who here knows CPR? That's a good number. All right. If you know CPR, you can add that in. So, the basic response is just give it, and when the paramedics or the police arrive, they will take over. But if you know CPR, you can give a dose and give them CPR until they wake up. And likely you'll know they wake up and they say, stop, 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 which actually does happen. CPR hurts, and they will push you away, and that's okay. Yes?
Did they come out just like that?
So I will defer to Officer Rice, because when we give it in the hospital, we give it as an IV, and they literally, in seconds, sit bolt upright.
Yeah.
If you ever saw Pulp Fiction, where she comes up, that's about what they do when we give it through the IV. What Monterey PD has described to me with the nasal is they slowly come to over about a minute.
The first thing I noticed both in the hospital and when we talked to officers is you get kind of flickering of the eyes. You'll notice the breathing starts to become more evident. So yeah, the nasal is a little slower on a little more gentle as they wake.
We actually had one day in the ER that the doctor and the nurse got in an argument while the patient was overdosing. We're fixing this, it won't happen again. But the doctor said, give the Narcan in the IV. And the nurse went, no, let's give it through the nose because it's less unpleasant for the patient. And then finally someone was like, dude, this person's overdosing, just give it. And then they did, and the person woke up and they were fine. But the idea is that it's probably less unpleasant for the patient to get it as a nasal spray. And when we do it as doctors through the IV, we give much lower doses, so it's not so horrible and abrupt. All we really want to do is get them breathing again.
That's all I need.
And then the next thing is, and this is kind of a little more beyond the scope of specifically saving a life, but don't forget we have 4, because Beacon House was here earlier. We have 4 drug treatment programs in this room that we're ready to help patients. And this is one of my favorite things. Recovery is the term that they use to talk about getting treatment from addiction, and they call it recovery because you get your life back. So if Officer Rice overdoses and his colleague saves him and he comes to my ER, we want to stabilize him and we want to connect him with treatment. Because I can't tell the number of people I meet who are wonderful people who were addicted in the past and now are great members of our society. Right? That's why we do this. Okay, go on to...
Yes. One quick comment nasal, remember it's a vapor, so it doesn't matter if they're slumped over or what position you find them, on their back, on their face, on their side, upside down, in a tree. You can give the nasal and it'll work in any position.
It does work in trees. I totally Okay, yes.
How long is your track, if you try to get somebody off the narcos, how long do you think, 3 weeks, or what's a good?
That is $1 million question because the answer is nobody knows. There are some people for whom they need a low dose of opioid every day for the rest of their life, and there are some people who can be tapered off in a few weeks. I will defer to our treatment programs, but what I know from our addiction doctors is every person, like my asthma is different than my daughter's asthma, that's different than my wife's asthma, that's different from my patient's asthma. Addiction's the same way. And it requires an individualized approach. And that's one of the things that we're working on to try to, again, to connect people with, yeah.
Does the police have these things with them?
You bet they do.
Yes, ma'am.
So that's the whole point is, I mentioned to someone earlier, or no, I said it earlier, the brain begins to lose oxygen, I'm sorry. When a person overdoses, they stop breathing and they don't get enough oxygen, and the brain will be damaged within 5 minutes of not getting oxygen. So when they carry Narcan, they get the drug in faster, restores breathing, and they can prevent brain damage.
And the real benefit to having this is that with the new trend of fentanyl, which is 50 times stronger than heroin,
That is correct.
there was just an officer down in King, I want to say King City or South County, where they were searching a car and some dust knocked up and he almost died.
Wow.
Yeah.
So the officers can use it on themselves, and it works on dogs.
Yeah, dogs can overdose on Narcan.
Drug dogs.
So
And they
as
save
this
several
becomes more
lives.
and more prevalent, I know I was telling this young man over here that now they're spraying fentanyl and marijuana from the black market. If you don't buy it from a dispensary, it's being mixed in counterfeit pills now. It's being mixed in our heroin. So having this
It's being mixed in
Narcan
our coke and our
available,
meth.
it's no longer just that heroin's the devil. It's now this fentanyl and carfentanil and there's
Remifentanil, sufentanil, alpha.
yeah, there's a bunch of different fentanyls.
Nice t-shirt, buddy.
Officer,
Yes, ma'am.
my brother died as fixated on vomit. So when someone is turning blue and everything, when they come back out, will they vomit?
I would probably defer to Casey Grover, but I think it depends.
So you put them in the recovery position.
Left lateral.
I can do this.
Position.
So when they vomit, it goes that way.
So when you administer the Narcan, will...
For everyone that I've administered, they have not puked. But I
So-
would still say it might be best to put them on their left side, just to err on the side of caution. But they're not going to want to listen to you because they're going to be, what happened, what's going on, why are you here?
But that's a good thing because they're breathing.
Yeah.
So the idea is in the hospital, if we give them a really high dose through the IV, they may vomit. And that's why, again, we try to use just a carefully selected dose. But outside of the hospital, we're going to want to, if you respond to an overdose, give it and roll them on their stomach. That's the safest, then they vomit away from their lungs. All right, should we do the injectable?
Yes. Okay, so talked about the nasal spray. So they just say you don't have the nasal spray, but you have an actual kit of the injectable Naloxone medication. So let me pass out. So I'm gonna go ahead and just pass out this kit, and each of you guys are gonna get a kit today, maybe both, but most likely this kit here with the a needle with 2 medications of the Naloxone medication and the other equipment to help you with the situation here.
Should we...
You could open it, just quick look what's inside there. So some of these kits will either have sort of your regular type needle here, or we'll have this kind of funky looking type of needle, it's in half. If you have this needle in one of those kits, what you're going to do is, the yellow part here is just twist it, and then open it, and the needle's right there. Just so you know, you're aware about, just safety precautions. And this purple is for afterwards, once you use the needle, you just close it up, and it's for safety, and you put it in, what is the little box called? The shark container.
And does the instruction come with the...
Yes, so each kit's gonna have instructions of how to use both the nasal spray and the injectables. And for best practice, usually these kits are distributed along with the shark container, really small shark container, but you can use this pencil box and temporary and then drop it off to your pharmacy.
Yeah, and Chomp Lobby has a sharks container, and literally you walk in, you open the thing, you put it in, you walk out. You may waive it a volunteer if you feel like it. Nobody cares, just put anything in the Any sharps go in the big red bin, meds go in the one sitting next to it. And just get rid of anything needed.
Is there one that I can repeat?
So even pharmacies have, you can drop them off, right?
No,
No?
most pharmacies do not accept meds or sharps unless they have a dedicated container. We have on our list out front where all the med bins and sharp bins are in our county. There's a living document on the Prescribe Safe website that we update whenever somebody changes a bin. But the place I tell everybody to go, because I know what's there and I know that it's not going anywhere, are the sharps bins and med bins at Chomp. But so Central Avenue Pharmacy, literally I received a photo before we put in our sharps bin and I used it as ammunition to get my sharps bin. At Chomp there was a huge bag of sharps that was left at Central Avenue Pharmacy overnight. After hours, they just, please can you get rid of these for me? And the answer was they could not legally. And so, you know, it was a big push for why we got sharps containers at Chomp. So just be aware that that's the one place I can promise it is and will be. The list has everybody else, but the pharmacies generally cannot take them unless they have a med bin, and then they can take out meds.
Now, when you use this, after this lesson board, when will you use this?
If,
You can actually use them together.
yeah, there's no upper limit on the medication, so if you use these and they don't work and you have access to this, go for it. People that are more familiar with syringes and needles, the injectable is wonderful. My preference for our community is the nasals simply because it takes a lot less. How I look at it is I've been on scene, I've done ride-alongs with our officers, and I gotta tell you, it is intense. When someone's dying in front of you and you don't have an entire ER staff behind you, which I do, and you're trying to take something out and fiddle with it and pull it up and click, and do I do air in it and where's the alcohol swab? Stay a push.
I read that you practically get one a day at Chomp.
Oh, yes, absolutely. I'm the person that sees every one of those and follow, yeah. It's heartbreaking. It's been crazy. I'm working on it.
So thank you for that information.
Yeah.
So yeah, so if you have either or, but the nasal is being sort of used more around the community, it's faster because it's a very intense, a very stressful situation. You want to get to it as quickly as possible, but they just say this is the kit that you have on hand in your trunk or anything. So in the kit, you're going to have a needle, gloves for safety, alcohol swipes, and then 2 of these vials. So the reason we have 2 vials is we're going to first use one on the person who's overdosed. If they don't come to within 3 minutes or so, then you're going to hit them with the next medication. So as you could tell, it takes time to get all this, and especially if you're stressed, you don't know. At the end, if you're not sure if they overdose, it doesn't hurt to use it. It's better to use it than not use it, right? So, and I believe anybody could sort of do this. You don't have to be an expert. Yeah, well, yeah, so and then, so use the alcohol wipes. And why not gonna inject you yet?
Oh.
Yeah, he's gonna do it. She's use the alcohol wipe. So, needle, the medication, you open the orange top, take it off, and it pops right off. Pops right off, you get the needle, and you just inject into this little gray little area here. You just pop it right in there. Again, it takes time. It could be you're very nervous, very intense. You just pull back, and you should take the medication, right? And then, obviously, when we talk about air, does it hurt to have some air in it or not?
If you're giving it that way, no.
Yeah, and then
In an ideal world, there shouldn't be any air.
yeah, you push it until
But
you
if
have.
there's someone, if you give it as a shot, like in the arm, it'll hurt.
Yeah, try to at least take some of the air until it comes out a little bit, and then you want to inject the patient.
Are you okay?
Okay.
Okay.
Wait,
In
In a carriage.
Oh, yes.
there's
Hey.
gloves and alcohol wipes.
So I'm gonna clean my hands as well as, actually the gloves are not actually alpha friendly.
He's
Leave the
been
hand
injecting
sanitizer.
Narcan in her.
So, well, yeah, well,
Those are cool.
So if you're wondering if it causes any side effects, we'll find out.
yeah.
So Kim, we got more Narcan.
Here we go. This is a good example of if I'm not overdosing and you give it.
Hit her with the second shot, right?
Check this
So, yeah, so you might might see someone maybe drowsy, whatever it is, right? Again, it's not gonna hurt them. It's better to use it than not use it and really go into the overdose effect. But right now, Amy's sort of kind of in and out, I'm not sure. I'm like, hey, Amy, are you okay? Amy. And then obviously call 911, have somebody, bystander, go do that, take care. You stay with the person the whole time, and then
Just remember, same thing as the other one. We assess the patient, we make sure we're safe, we call 911, and then what I'm going to do is I'm going to demonstrate first, actually, is when we're giving this, we want to find kind of a fleshy part of the body, so the deltoid up here on the shoulder or the thigh. Since she's wearing a short sleeve t-shirt, it's easier.
Yep.
So I'm literally just kind of going to pinch some of the tissue so it creates a little bit of a kind of like a raised area. And there's no science behind it. It's just aim for a spot where there's muscle. Right? So this shoulder muscle right here is the deltoid. So we're just going to do that. Who got a flu shot? It's exactly the same what you're aiming for with a flu shot. Do you want to switch? You want to do it to me?
I'm
You're
good.
good? Okay. All right.
and just in case, it's all instruction here so you know where to inject them. And the muscle areas here, and the thighs and the buttocks.
And part of what's a little more complicated about the injection is there's no time and there's a little bit of time. And that may be kind of too hard to think about in this group, but in the ER, if we need to get access to somebody and they're either flailing or something, we can't do it, we may not be able to get into clean, and we just want to get the medicine in their system. But in an ideal world, let's say for example, we see Amy use and then slump over and we know what's going on, we'll literally like, okay, gosh, let's clean the skin, we'll get everything ready, I drew up my medication, okay.
Time sticking.
What I'm going to do is I'm going to, again, make an area here, I'm just going to clean the area, there's no science to this, you just want to rub the alcohol on it. I'm so sorry. And then you're going to poke, and then you're going to inject,
Medication's in.
and then we're all done. What you can do is you can also just put a little bit of pressure on there afterwards. And you can massage it. Nicely done. And then the other thing is then I don't want this to poke anybody. So that's where that sharps container comes in. Is this a safety? Is this a safety one? Yeah. Cool. So there's a little red button on the back and you push it and now the needle.
It's gone. So there's so many different type of needles that come with the kits. Yeah.
Nicely done.
Yeah.
Very cool.
So these are really easy. Sharps container and then drop them off. So let's say Amy's still slumped over.
Yeah.
Hit her again. So then, you're counting there, you're part doing CPR, checking her, making sure she's good to go. If she's still doesn't come to, then obviously you do the same process again, do it again.
If you can, the other arm is fine. If you can't, the same arm is fine.
Is it okay to go through clothes?
In an ideal world, no, but if that's the only way you can do it, yes. So kind of the way we think of it is the thing that we have to get going is the breathing. And if you get an infection in your leg because we went through your jeans, we'll deal with it. Not ideal, but if that's the only thing that we can do to save your life, we'll do it.
So
We'll
she
take care of the
has
rest
a
of the
thick
hospital.
jacket, jeans. Obviously, you use pressure, right, to get the needle through the material of the jean and the jacket. Usually, it's thinner jeans.
So yeah, I mean, we've literally given people shots through their jeans in the ER because that's the only way we can do it.
Yeah.
100%.
Now, is everyone ready to get in line and inject her for
So you can tell, obviously the medication's in her system, it's not gonna hurt her, it's not gonna kill that person, it's better use it than not use it at all and have that person pass away. And the other thing, talking about coming to, yes, there's people that are gonna just kind of come to and not know what's happening, right? Assess the situation, be safe, and when you inject the medication, kind of give yourself some space, because if they come to, they're gonna be friendly sometimes, or not know who it is and might attack you, hit you, punch you, whatever it is. Safety is really important. By then, hopefully, the ambulance paramedics are there to take over and probably talk to you and get information about what happened, what's going on, how many injections did you use, and so forth.
And the other thing is if you were worried, the dose of this medicine and it's given in the muscle, the medicine comes on slightly slower than it does when we give it IV. So it's a kind of a similar reaction to the nasal when they wake up more slowly. When you see the paramedics put in an IV and give it IV, it's very different. Just realize again that you're saving a life and that everybody, if you give them a dose of this medicine, has to go to the hospital. 100%. Methadone lasts 24 hours, this lasts 45 minutes. You can literally, if Officer Wright overdoses on methadone, I can save his life and watch him re-overdose, save him again, re-overdose, save him again, re-overdose. I mentioned sometimes people have to get IV drips of this stuff. So everybody goes to the hospital. That's why we call 911.
Yeah, because what happens with the medication, it takes off those receptors, just cleans you, right? Cleans you clean, and then depending on the potency of the heroin, it'll just take over those receptors again and go into the overdose mode again. That's very important to get them paramedics on site. Even though sometimes when I was interning at Access Support Network, some of the clients that were coming in, they wouldn't call 911 because they felt it was the stigma, police officers, whatever it was, whatever they were thinking about, they were like, I'll just use this and try to save them. If not, use another one and another one. And some clients will come in and get like 4 kids, and I'll just kind of ask them, so what do you need 4 kids? So like what I do in Chinatown, I'll stash them on the tree, I'll stash them behind a tent, so somebody knows that it's there to use. Because they know fentanyl was being very active in the community with the heroin and stuff. So they're using that preventative measure there. So, any questions about this? No? You guys are ready to use
Can we
it?
give a round of applause to Amy? All right, so we've got some food. Thanks to Valley Health Associates for the food. We have a tree that if you know anyone who's had an overdose or have lost anyone from an overdose and you want to have a little memoriam for them, there's a space there. There's a couple of leaves already on the tree. And then we'll be back outside of the tables and sharing information if anyone wants it. Yes?
So it's not a question, but just a statement. Kudos to Dr. Close, Dr. Grover. I am a community hospital critical care nurse, 22 years. Watched how this has really stormed our nation. And I consider a godmother, godfather to our community when it comes to battling this. And they're not just doing it locally at the community level, but they're actually taking this nationally. So kudos to you guys. We're so proud of you guys.
Just I wanted to tell you, officer, thank you for your leadership and your ability to inform and drive and to even speak truth to power. Because in dealing with community and residents, then basically when we have the opportunity and the authority to be able to answer questions and make ourselves vulnerable in order to be heard and to be present, that you are the face of the future and you are the face of what a resource officer looks like. Thank you very much for being here today.
I'll add one other thing. I'm a city councilman in Salinas and a board member for Community Human Services. And to Valley Health Associates and the leadership that Amy's put into today's clinic, just want to acknowledge this is a growing and strong, very large issue in our community. And you need to know that your elected officials, it's on the map, and we're going to do everything we can to support.
I know for the community at Valley Health, I can speak for our organization. If you guys ever use your Narcan and need more, call us and we'll provide you with more free of charge.
How's it going in my truck?